I'm Paul Markovich, and this is Worthy, where we are creating the healthcare system we all deserve. It's my pleasure to welcome Dr. Geeta Nayyar, also known as Dr. G, who is a leading physician-technologist, investor, author, and globally recognized chief medical officer, and one of the most respected voices shaping how artificial intelligence and innovation show up in healthcare. Dr. G has served as chief medical officer at both Salesforce and AT&T, and she's known for building what she calls the trust bridge, making sure technology is grounded in clinical reality, human empathy, and the lived experience of patients. Whether advising companies, caring for patients, or helping leaders navigate rapid change, Dr. G brings clarity, credibility, and heart to the conversation. And I am excited to have her here today. Welcome, Geeta.
Thank you so much for having me, Paul.
The first thing I have to check in on, because I was reading about your background before this started, that it says here, or at least I read, that you were actually admitted to the University of Miami Miller School of Medicine at the age of 17. Is that accurate?
Yes, it is. So I was in one of those few accelerated medical programs that you get into out of high
Mm-hmm.
school. So I'm a proud Miami Hurricane. So I went there for 2 years of undergrad and
Wow.
then 4 years of med school.
All the things and all of your achievements, I think the one I find the most amazing is at the age I was trying to drum up the courage to ask somebody to prom, you were getting admitted to medical school.
Too funny, too funny. I come from a family of docs, and I have always just really, really loved science and medicine and people. And so for me, it was
Yeah.
like just medicine was always, always what I wanted to do. And so I think that's really cool. Those programs are really cool for students who
Right.
really think they know. And if you don't, you apply out or you do something else.
So was it that family history that really got you passionate about healthcare and medicine?
I think so, and I will also share. So I'm a rheumatologist by background. My mom actually has a really rare autoimmune disease, and
Mm.
as a South Asian family, we always all of the whole family goes to all the appointments, right? So my whole life we kind of went to these appointments with my mom, and she actually had such a rare autoimmune disease that she was misdiagnosed her whole life. And so I became a rheumatologist. I went into rheumatology for that reason. And I actually diagnosed her correctly at the time that I became a rheumatologist, and my mom was actually dying at the time. So it really inspired
Wow.
my path, not just into medicine, but into rheumatology and largely my path into health tech, because a big part of her story was the data just wasn't connected. So on top of having esoteric diagnosis, the docs in charge, they just didn't see what, pulmonary and cardiology
Yeah.
and what everyone was doing at the same time. And so I really saved my mom's life. My mom is now close to 80, lived to meet my daughter, had a full life,
Wow.
but she was just wrong diagnosis, wrong diagnosis. And I, just in the nick of time, we were able to figure it out.
Wow. I love happy endings like that. It probably also fed your passion for writing the book Dead Wrong, I'm guessing. You talk about how common and dangerous it potentially is for misinformation to be spread in healthcare. I'm wondering if you could maybe give another example of that and what we can do to address it.
Well, first of all, I want to talk about the definitions because I think people don't necessarily always understand. So misinformation is literally just a miss, right? It's kind of like a rumor. You just got the information wrong, and then you told three of your best friends, and that's why we say never pass on a rumor, right? Because then this thing becomes bigger than it should be. But disinformation is actually much more dangerous because this is actually a organized mission to dupe the masses for some sort of gain, whether that's political, whether it's monetary, but it
Mm-hmm.
really is with the intention of spreading confusion. And in today's world of health, it's just become very lucrative, frankly, right? It's just become very
Mm.
lucrative when we look at podcasters, entertainers, celebrities, influencers. And so that's why I think it's gotten so noisy for the everyday consumer and frankly the everyday physician and healthcare leader to do the business of healthcare because there's just that one hack. There's just this one
Yeah.
hack, Paul. If you do just this for $5.99 and that one supplement, you don't need a
Yeah.
doctor, you don't need a hospital, you don't need the healthcare system, right? And so that's the real issue when we look at the undercurrent of what's going on today.
Mm-hmm. Now, one of the other things that you're passionate about is applying and using technology, including artificial intelligence, to help the healthcare system. That healthcare system has proved pretty immune to actually effectively adopting technology over many years and decades. What gives you hope, and what do you think needs to happen for that to change?
Well, actually, a big part of my career has been as the chief medical officer, kind of connecting the dots between technology, business, and clinical medicine. And I would largely say that the biggest allergy that we have in medicine to technology is that we have so much technology, legacy technology today, that has really hindered care, right? And the EHR, the electronic health record, probably being the biggest example today, which is that it was certainly started with good intentions, right? But you know what they say about the path, right? The path to hell is built on good intentions. And so we solved, let's say, three problems, but we created about five new ones. And when we think about what the purpose of the EHR was, and we were promised, right? We were promised this was going to be more efficiency on the back end, on the front end. We were promised better revenues. We were promised better trust building and communication, data exchange, and a lot of that didn't happen. And instead, we found ourselves with more data silos, more friction in the system, a lot of information, but not really valuable information. And we really created a barrier between doctors and patients, which is not, which should never be the goal of technology, right? The goal of technology in my mind
Mm-hmm.
should always be to bring the doctor and the patient closer, less friction, less fax machines that I know you're a fan of. And thinking those things through, and I think so much of the problem with technology today, and even the AI conversation, right, is we're so focused on the technology. Like, how can we be,
Yeah.
when I speak to hospital leaders and healthcare, we want to be the most automated. We want to be paperless. We want to be, you know, those are the wrong goals, right? Those are the wrong goals. You want to be the best enterprise that is the most trusted enterprise by doctors and patients, right? What that looks like should have nothing to do with whether you're paperless, should have nothing to do with whether you're automated, right? The staff should feel supported. They should feel that they have the right tools at the right time. And some of that is probably automation, but some of it's probably not, right? And so I think
Mm-hmm.
that we often miss the goals because we get so excited by innovation. Most of us in the industry are in business or tech, but when you talk to clinical leaders and you talk to the everyday patient, they don't care about that stuff, right? They want the diagnosis, they want the treatment, and they want to know they can
Right.
trust the team that's in charge of them. And they hope that they have the greatest tools at the bedside to do that. But they don't care about the tools. They don't care how we do the job, right? They just want to get to the destination.
No, I share that frustration every time I go to industry conferences. Everyone wants to talk about technology and artificial intelligence, and I'll say all the time, you can't put AI on top of a fax machine and get a better result. Like, you're going to have to do something.
Exactly.
There's a whole series of things you need to do to think about, as you said, what is the outcome for the patient, and how do we facilitate that outcome and use technology to that end, not just use it because there's some cool bumper sticker slogans about and how to do it.
And we have a lot of blind spots in our data, right? If I can jump in for a
Yes.
second, we have a lot of blind spots in our data, right? And the AI, everything we know about AI, and we don't know everything about AI, is that it's as good as the data. And already, when I open up a patient chart in my clinic at University of Miami, I know half the information is wrong because I'm looking at a chest X-ray with a patient who clearly has COPD, but the chart says non-smoker because
Yeah.
somebody copied and pasted something on the one day this patient said they stopped smoking for 2 weeks, right? But clinically, and my judgment, I already know this is a pack-a-day smoker for probably over 15 years. And that took me that long, right? But if I
Mm-hmm.
was to rely on AI to figure this out based on the chart, oh, I would be getting all kinds of wrong differential
Yes.
diagnoses, right? And so understanding also human in the loop, but also understanding the data is not pure. So we have to really automate in the right places and at the right time.
Yeah. Well, and make sure we've got our digital house in order as much as that's possible. When you just step back and look at the healthcare system in general, what do you like about it, and what do you see are the major problems?
No one ever asked what I like about it. Thank you for asking that because I really had to think about that one. I'm like, we never talk about what we like because it's not all bad. It's certainly not all terrific, but it's not
Yeah.
all bad.
Yeah.
I will tell you, as someone who is a global person talking to healthcare leaders around the world, and as someone who comes from a family from India and is very well aware of global health. I think one of the things I appreciate the most about the American healthcare system is that we have the most innovation, the most specialists. I mean, if you break your left pinky toe and you want to see the world expert on the left pinky toe fractures, you're going to find him in the United States, and you're going to be able to get an appointment and go there, provided you have the resources, of course, right? But that
Yes.
is available to you. That is available to you. Now, you want to get a mammogram and a colonoscopy and some good primary care. This is not the healthcare system for you, right? So we do great specialty care. We do great innovation, cutting edge, latest science, therapies, you name it. We are the king of the world in that space, but we're not so good at the basics. Right. And so when we look at
Mm-hmm.
population health and we look at the value for the dollar, right, we have some of the most expensive healthcare in the world. Everyone, I think, appreciates that. But we have pretty terrible outcomes from a population health perspective, particularly when you're looking at infant mortality, maternal health, the basics, right? But you got a left pinky toe fracture. I mean, we got the guy, we got the gal. And so I think that's really the biggest beef, which is so unfortunate because the basics are
Mm-hmm.
actually quite easy, much easier you would think than the specialized care.
So if I now, so what about the things that you think are problematic? You mentioned obviously we're not good at the basics, but why aren't we good at the basics, and what needs to change?
Jerry Maguire said it best, show me the money, right? It is because the money doesn't line up. I mean, the truth is we don't
Right.
get paid. We don't get paid to talk to patients. We don't pay doctors to really talk or counsel or educate, which is the best prevention in my opinion, frankly. And we pay to cut. We pay for surgeries, we pay for procedures, we pay for volume. Value-based care is simply not really a reality. And we don't pay for prevention. We don't pay for the basics. We would rather pay for breast cancer. Rather pay for end of life care than actually pay for the mammogram, pay for the conversation around why a mammogram is important, why an annual visit is important. Those are the basics. And the reimbursement, it all goes back to the reimbursement. And we just don't have good reimbursement models. We also have a system. I work with medical students and residents at the University of Miami. Our med students come out of medical school with like $500,000 in debt. So that's why they become the specialists of the left pinky toe, because that
Right.
specialist makes upward of $1 million a year, whereas the primary care doctor, you know, very different numbers, very different numbers, a quarter of that maybe. And so
Right.
we've set up a system where we don't reimburse for preventative care, and we really get our doctors at an early stage in their career where primary care and prevention is simply not a reality financially. So it's this ongoing system. And then you put that in the context of all of the mis and disinformation out there, where the consumer is being told, forget medicine, forget the institutions of healthcare. I'm Dr. TikTok. I've got the one hack to get you to be 100 years old doing squats and doing jumping jacks.
Right.
Subscribe here, right? And this supplement's just $5.99. And so we've confused the heck out of everyone. And the money is, the incentives are not aligned. The incentives are actually not aligned in the best interest of the patients most of the time.
So if I gave you a magic wand and you could do anything you wanted to with it to change the healthcare system, obviously you would change the incentive system, I think, from what you said, but what else would you do with this all powerful magic wand?
Gosh, well, first of all, I would really love to actually have a magic wand. Thank you for the question. Um, you look a couple of things. So no question about the reimbursement model. Reimbursement models have to change. We keep talking about it, right? There's so many special interests in the mix that I'm
Hmm.
not sure we actually will ever get there, because I'm certainly not the first one to say it. But the reimbursement model certainly needs to change. Medical education, funding of college, funding of medical education in general, residencies, these things all go together. They all go together, right? So we have to be mindful of, why should someone pick a career in medicine, pharmacy, nursing school? It's all, again, the care team, right? And who is going to fund that? Where are folks going to work? How do we also serve, when I think of the underserved, particularly rural America? There are so many opportunities to get doctors in those areas. But again, it comes down to reimbursement. I mean, rural America takes care of some of the sickest patients for less money than the rest of the country. And you're lucky if you can even get a doctor to work in those areas. I will tell you, I am the product of rural America. My parents are both physicians from India, foreign medical grads. In the 1970s, there was a physician shortage. So I was born in Beckley, West Virginia. But rural America actually offered foreign medical grads opportunities. They still continue to because they cannot find American doctors that are willing to go into those areas because it all leads back to reimbursement. I also think we are in a place where we have to really elevate the profession and the conversation around science and medicine. If everyone on TikTok is an expert, then no one's really an expert, right? And so we went from really making the profession of medicine a really heroic thing to now a big loss
Hmm.
of purpose and respect and even an interest in the conversation around science. And so I think there's a broader question around regulation, particularly the social media space. Meta can fact check on Monday, and Tuesday they can say, oh, there's no need to check the facts. It's, freedom of speech. And so there's a bit of a dance going on in the regulatory space as it relates to social media. Meanwhile, we now have decades of research telling us that social media has affected the mental health of children. It has caused addiction, gaming like algorithms. And so there's a real health conversation now happening in the media space. And that space is largely unregulated. And then you add this layer of AI onto that. And while I'm
Yeah.
obviously pro innovation, I'm pro technology, there is a health component that I think we never really appreciated in that conversation, but it's starting to become very obvious that that is a conversation that needs to happen.
So what are this? How would you see us building a path back to establishing the trust we need to have in the healthcare system, the people and the institutions in that system? What do we need to do to get to that foundation of trust that's just so fundamental?
Well, I think first we need to acknowledge that there has been a loss of trust, right? I think sometimes it's a very sensitive topic and it's tough to acknowledge that, but I think we have to acknowledge it, that there has just been a loss of trust in the institutions of health, and some of it richly deserved, frankly, when we look at Tuskegee, when we look at the way
Hmm.
communication in general happens. I mean, they're not unfounded, but there has certainly been a tipping point and alternatives that are being offered that are actually substantially harmful as opposed to helpful or neutral. And so I think that acknowledgement is key. I'll give you a few examples. So Kaiser, and on the enterprise side, if I put myself in the hat of being a hospital leader, or I speak to many hospital boards, they don't like for their doctors to be out in the social media space or media in general talking about anything related to the hospital. So the first thing, if you're a physician influencer, that your hospital will tell you is feel free to have social media. Do not mention the hospital. You do not speak on behalf of the hospital. I mean, there's just a litany of all the things that you can get in trouble for, which is not exactly appealing, right? And certainly not one that's building trust, right? So
Yeah. Do not pass go. Do not collect $200. Go straight to jail.
exactly. And exactly. And one of the best quotes in my book, which I really loved, is that mis and disinformation grows in the dark, like mold on bread. And that has
Hmm.
been what has happened because there's been this vacancy of the voice of science and doctors, largely because of enterprises saying, we're so afraid of liability. You cannot, there's an arm's length between us and our clinicians, that vacancy has now led to this mold, right? And so I think hospitals have to re-examine that. Payers have to re-examine that. Everyone, pharma, life science, med device, because on this alignment of trust, we're all on the same page. We are all the institutions of healthcare and we're all being questioned. And so one of the cool things that has happened, Kaiser recently launched a TikTok channel, and it's run by Kaiser,
Oh,
but it highlights all of their doctors. So they've got their cardiologist in there making recipes saying, yeah, this is heart health. This is how we eat in my house, right? And then you've got your GI doc talking about all the things GI docs talk about, but it is endorsed by the enterprise. It is supported by the enterprise. I actually did a grand rounds at Kaiser and I said that to them. I said, how did you do this? How did you get to yes? And they said it was hard. It was hard. It was a lot of coffee. It was a lot of whining and dining of the lawyers and the risk management people. But that's what they said. They said we had this conversation around trust, that if our patients are going to go somewhere, why would they not go to the Kaiser TikTok channel? Because there isn't one. That's why they're going to the other channels, right? And so I think that's a great start is when an enterprise says, enough. We can't leave this vacancy open, right? So, and when you look at providers, you look at payers, same thing, right? What the payers are aligned. If you get your mammogram, that's a good thing for everyone. It's a good value for the consumer, the member, the patient, the doctor. So if you're not part of the conversation, if you are not empowering that conversation, if you are not making sure that you also can stratify your member and know, hey, this patient is like right there to get a mammogram. Like it's like they're right there. We know they want to do it. So we're going to give them this piece of information. We're going to talk to them in the right level of language, culture, et cetera, et cetera. It sounds so simple, but that is what breeds trust. It's this being in the conversation, personalizing the conversation, scaling it, and also the accountability. Because what I think is really interesting is when you look at said podcaster, said Dr. TikTok, whoever it might be, they're not accountable, right, Paul? They get to say Monday, get vaccinated, Tuesday, I changed my mind, Wednesday, take the supplement, right? They can constantly change. And I think the consumer of today, hopefully, will slowly start to realize there's a difference between entertainment and where you should get your information. And I think enterprises that
Yeah.
can find that balance of, hey, and if you have a question, didn't like what you hear, had a bad outcome, make an appointment. Come and see us. Like we are accountable. This is what we do every day. We're in the business of
Hmm.
medicine. But I think that's really what it takes. In today's world, it takes an acknowledgement, it takes a marketing strategy, which includes a content strategy, but it's actually using the best assets we already have in all of our organizations, which is our teams, our staff, right? And ultimately scaling the doctor patient relationship, because it doesn't matter which stakeholder you are in the healthcare system. It really does go back down to that core relationship, whether you're life sciences, med tech, payer, provider. Bringing that relationship together is always going to drive the business outcome that is most needed. And right now, there's a huge wedge between the doctor and the patient, largely because of technology, actually. And so the same technology can be used to bring that relationship together, but we kind of have to get out of our own way, if that makes sense.
One of the things I really like about that example is you're also meeting people where they are and where they already
Exactly.
are. And so it's kind of catching them hopefully at the right moment and engaging them with the right information. So yeah, that's a great example. Speaking of which, one of the things we are advocating for here at Worthy is to create what I call a Wenberg-like shared decision-making model. Some of my formative years, and when I started in healthcare, were reading some of Jack Wenberg's work at Dartmouth, where he had studied the variation in clinical practice patterns and realized that there was a lot of times they weren't following evidence-based medicine. And so kind of created this idea of if you could actually get the latest available evidence on a patient's condition and make sure that both the patient and the physician were seeing that and then using that to have a dialogue to decide, how to treat a patient, that would be a very powerful way to get to better outcomes, better quality, more satisfaction, and even lower costs. And I think his studies sort of borne that out. And I've always been wanting to do that, but feeling like the technology didn't necessarily support it. But now, with where technology is going, especially with AI, it feels like it's not just a pipe dream. It's something that we could do. And I'm just curious as to what you see in terms of the ideal patient-physician dialogue at those moments of truth, and how we can best support, a high-quality, consistent decision-making for everyone.
Well, I love the concept of what you're working on at Worthy because I have a trust framework, the Dr. G trust framework, and I call it the 3 A's. So one is accuracy, right? Just because someone sounds credible and it sounds really confident, confidence is not accuracy, right? So you're talking about being accurate, being precise, right? So that's number two. That's number one. Number two, accountability, right? So this is shared decision making. This is I'm accountable, you're accountable, we're both accountable, right? And then the last A is actionability. So this isn't just because we want to make a PowerPoint, we want to share a piece of information. We want to lead to some kind of action, right? We want you to lead to an action that is in the best interest of your health, right? But with all those in mind, the accuracy, the accountability, but it's about the action. Otherwise, it's just a fun exercise in a lab that doesn't go
Hmm.
anywhere.
Yeah, I like. It's always nice when you have something that is easy to remember. Three A's: so accuracy, accountability, actionable. What role do you think technology can play to help create that 3A environment that you described?
I mean, I think it's very aligned with what you all are doing. Number one, making the data available, being transparent. Right. We have a way now to make data transparent and to share it, just to be able to share it. Right. It's easy to share, easy to make it transparent. Accuracy, it's easy to check. Where did it come from? What is the source? Is it evidence-based medicine? Is it not? Is it aligned with what professional medical societies are doing? Is it aligned with global health standards? Is it aligned with practice specialty standards? Checking all of those things is really, really critical. And again, accountability, same thing. Who's in charge here? Who's the human in the loop? Because the technology is great, but when I don't understand something or it didn't work or my claim got denied, whatever it might be, who can I call? Who is it that's accountable? Right. And on the action piece, look, this is maybe the biggest friction in medicine. It's like, I had my prescription. I didn't fill it. I don't remember what the question was. What was it they told me to do when I leave the hospital? We have an opportunity to support actions and drive next best action and care. And technology can make all of this possible, but it's all in the implementation and with an eye towards moving those three things.
I don't know if you still hear this, but when I talk to some physicians about this, not all, and not even most, I'd say, but to some, there's still a conviction that patients don't really want to be engaged and know all that information. They just want to be told by their doctor what they need to do. I don't know if you hear that, or if you feel like there's anything we need to do to help support physicians in engaging in that kind of model where there really are, it's a joint decision and not just an instruction manual.
I mean, so my answer to that is yes, right? Yes, and which is yes. I have patients who say, Doc, I don't know what the heck you're talking about. Just tell me what to do. If I was your sister, if I was your mother, your brother, et cetera. Right. So
Right.
it's but that's the whole point. Because then on the flip side, I have patients who say, well, I want to take this home. I want to research it. I want to talk to my family. I'd like to make that decision next time. Can I make an appointment? Can I see you relatively soon before I start this therapy?
Yeah.
So it's different strokes for different folks, but the idea is that you are able to offer it, right? Because it's very different to be offered it as opposed to not even be able to offer it. Let let the patient make the decision that
Hmm.
I don't want to think I'm in your hands, da 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 da, or not. And I have patients on all spectrums of that. I also have patients who change their mind and say, "Remember when I said that
Sure.
I didn't want to know?" And well, I went home and da 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 da, and my neighbor said da 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 da, my mother-in-law, right? And so we get to change our mind, but these are big decisions, and I'd also say it depends on the diagnosis, right? Sometimes we're dealing with
Right.
small, non-acute things, and patients are like, "Just tell me what to take. I'll pick it up at the drugstore." Now, when we're talking about chronic diseases, terminal diagnosis, really scary side effects with certain medications or procedures, that's generally not the conversation. The conversation is going to lean towards, Doc, I need more information. I need to discuss this with my family. I need time to think. So it's all spectrums and it's all specialties, Paul, because right in there,
Hmm.
you're depending on your specialty, depending on where you fall in that, that's why those conversations are different. Now, what I would say to the physicians that resisted, I do also understand that perspective because here's the thing. Our notes are complicated. Our stuff, our jargon. I mean, this is how we got into the mis and disinformation mess, right? Because the
Hmm.
entertainers out there make it sound like there is just this one hack. And somehow your doctor's holding back on you because they talk, everything
Right.
they say is so complicated, right? And the truth is, science is complicated. There's nuance to everything. And so anyone who sells you a shortcut is selling some kind of snake oil in some way because there is really no shortcuts to the human body that are one size fits all. So my only caveat to, what you were mentioning is that as long as it doesn't cause more confusion, because sometimes in the intention of transparency can also cause confusion. And I would say that whether we were talking about my accountant, for example, when he tries to tell me and I say the same thing and I'm like, so I tried, I don't know what the heck you're saying, just tell me what to do and keep me out
Right.
of jail. Right? Like,
Right.
and lawyers, and I mean there's a million other, my mechanic, something goes wrong with the car, I could care less, just fix it. I'm not going to understand what you're talking about, right? Now, my
Hmm.
husband wouldn't say that. My husband would be like, "What? What are you talking about? What about this? What about that?"
Right.
So I think as long as it's building trust, it is truly shared decision making, and there's an eye on the goal, which is what is the goal
Right.
of this. That's important because if it causes more confusion, you could do the opposite, right? It could end up causing the opposite, which is I don't understand this word, I don't understand this lingo, I don't understand this number. And so you just want to be
Right.
mindful of how it really plays out and rolls out in real life, if that makes sense.
Right. Oh, sure. I mean, if we dropped a 30-page New England Journal of Medicine article on them with all kinds of scientific and technical jargon, it's transparent, but it's not necessarily helpful to the patient. So,
That's right. That's right.
when you look at your framework of accuracy, accountability, and then being actionable, where do we need to make the most progress, and how do we do that in that equation?
Gosh, I mean, honestly, all three. I wish I could
Okay.
say one more than the other, but all three. I mean, right now, if we look at accuracy, again, the medical record a lot of times is just wrong. It's just wrong. I
Hmm.
mean, I'll tell you personally. I mean, I go into my primary care. I can't tell you how many times I've had to correct just my name. Like we have a chart for Greta
Wow.
Nagar. We have a chart for Greta Nagar. I'm like, great. I'm not Eastern European. There's no R except in my last name. So, I mean, there is just like there's a basic accuracy, right? Basic accuracy. And I will also tell you very candidly, as a physician, I still remember one of the cases that I messed up a night on call that was just a crazy night on call. You know, we had like 10 Jose Garcias. We're in South Florida. We had 10 Jose Garcias get admitted. I happened to look at the wrong chest x-ray on the wrong Jose Garcia and got the whole treatment plan correct on the wrong patient. So accuracy,
Wow.
we are still dealing with accuracy. We are still dealing with accuracy. And we have so much data right now that often it is very easy to get things wrong. So I think the cleanup of the data, the accuracy of the information is really critical. Before you talk about shared decision making, are we looking at the right playbook? Right? That's really critical. Accountability is often shared. Often shared. There's always a team involved, but of course the buck has to stop with someone. Who is that? I don't know. Is it the insurance company? Is it the doctor? Is it the patient's responsibility to do certain things, right? So there's also this accountability question. And sometimes I do think that we talk about the patient and the consumer like this passive person on a train, right? And the reality is, I can't make you go home and eat a good diet. I can't make you go home and walk. I can only advise you. And then you have some accountability even in your own health and your own care, right? So this idea that the doctor or the healthcare system is all accountable and all encompassing, that's not true, nor should it be, right? And so
Right.
how do we think about those things? If I had to pick, perhaps actionability to me is more important as someone who's practical and a pragmatic person, right? As long as you get to the action, if it wasn't a perfect road, I'm still okay with that as long as there was a good outcome, right? So if I had to pick one, I would say that action is largely more
Yeah.
important. And hopefully it's the right action, because the worst thing that could happen is that because of some of this, you actually led down the wrong action that may or may not be reversible. And so I think that's perhaps the more important one, but I think they're all important.
So earlier you quoted the famous Jerry Maguire about "Show me the money" and the importance of incentives. I'm wondering whether there's something that needs to happen here on incentives that helps with accuracy, accountability, and actionability. Anything you see that we need to change in terms of the payment models to help reinforce those things?
Oh, 100%. I mean, if we think about billing and collections, if we think about, um, we're still trying to figure out how to share data. I mean, we went on this whole digital highway because it was supposed to be that we were going to share, and then I wouldn't have to repeat the labs because the doctor down the street did it. I mean, you and I know that's not happening. That's not true, right? But if we were, and there's always a fine dance between innovation and regulation. But if there was an incentive and or a penalty for not doing these things, for not having records correct, for not having the next best action actually completed in a timely fashion, I think absolutely reimbursement has a role to play. And so much of the dysfunction is currently this way because there is no reimbursement or penalty for many of these things, right? And so it's so large. It's also large. And I would also say that part of it is in the risk taking, because we are also living in a time where liability in healthcare, anything and everything we do in healthcare comes with so much liability that we're so afraid. We're so afraid sometimes to do the innovative thing. We're so afraid to share. We're
Yeah.
afraid to share the data, right? Because it could be wrong. And then now, am I accountable for that? Am I liable for that? And so there has to be a balance, I think, with reimbursement, but also liability. And look, frankly, we saw that with telemedicine. We were told forever as docs, can't do telemedicine because of the liability across state lines. And where did you document? And da 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 da. And you didn't do a physical exam. And then as soon as there was a need, a massive public health crisis, COVID, all of a sudden it was like, no, no, you can do it. We're going to waive the liability. And man, telemedicine is now everywhere. Now it's like, how can we
Right.
optimize it? And it was because of the liability. It was the liability that was the biggest stopgap. And spoiler alert, doctors were doing telemedicine long before we were paid for it because we knew it drove the outcome. I mean, if I had a patient who was out of state, needed something,
Hmm.
I just took care of them. I didn't actually get paid for it, and I didn't think I was going to get sued. But now to have a system that actually supports that kind of innovation it's a huge driver of adoption and innovation. And so I think that balance of reimbursement with liability is one that is very unique to healthcare and has to be addressed.
Are there any other steps that you haven't already talked about, Geeta, that would help empower the patient and lead to a better engagement and dialogue with their physician?
I think one of the things that we haven't really explored is the continuing consumer movement, right? If we look at the wearable market, if you look at the wearable market in 2019, pre-pandemic, was something like, I think it was a $32 billion market. Post-pandemic 2022, it was something like a $72 billion market. And I don't know what today's number is, but it's even bigger. And that to me is one of the biggest indications of consumers saying, I want to take control. I want to take control of my health, whether I have a doctor or not, whether I get a doctor's appointment, whether my insurance pays for it or not. I am going to spend 150 bucks on this watch, on this ring, and I am going to measure my mood, my steps, my heart rate, right? Because I feel
Yeah, my sleep. Yeah.
I am the do it yourself person. I am going to figure out, and now I'm able to figure out, oh, when I have a glass of wine, I don't sleep so good. And then I'm not able to write. So, you know what? Now I'm actually going to drink only one glass, not two. And so we
Hmm.
see consumers changing their behavior based on these remote patient monitoring devices, which have, Paul, they're not reimbursed for the most part. Like at scale, we're not reimbursing for these. Maybe some employers, maybe some challenges, but
Right.
people are paying out of pocket. And I think to your point, we've actually underestimated the consumer in many ways. And we've underestimated the do-it-yourself component, which is why I like what you all are proposing, which is to say, what if we shared? What if the goal was shared decision making? And maybe part of the transparency is this is new. It may not be accurate, but we're going to have a go at it anyway, right? We're going to have a go at it anyway in the spirit of getting to a yes. And I have to tell you, as someone whose patients comes in sometimes and wants to share every heart rate they've ever had since the last time I saw them, it's TMI. I'm like, yeah, so clinically, not relevant. Just let me know if you felt short of breath. Tell me when something happened to you. Otherwise, like, I'm not looking at your heart rate for like 100 pages of data, right? It's not worth my time. And so
Right.
there's something there. There's something there, whether it's the reimbursement model, whether it's working with some of these direct to consumer models. But I think we're in a place where people are really ready to kind of skirt the healthcare system, and they're okay to spend 50 bucks. They're
Yeah.
okay to spend
Yeah.
100 bucks if they feel more in control, because it does go back to trust, right? They're like, I trust this data because it was on my wrist. And by the way, I don't even know how accurate it is when it's falling off my wrist like mine. But there's something about that. There's something about the consumer saying, I just know because I am in charge and I want to feel that I'm in control here. And they're looking for doctors, nurses, when they do enter the healthcare system, they do want someone who acknowledges that and will work with them. And so there's something there. I won't pretend to know the answer, but I do think, particularly as we think about employers and the role that employers can play in this regard, there are any number of ways to give the do-it-yourself movement a real shot and get even more sophisticated, whether it's labs, whether it's interpreting if you have AFib. I think we'd be
Right.
surprised how dialed in people are to their health.
One of the things I love about your work and everything you said is that it is very consistent with the standard we talk about at Worthy, where we want for our loved ones when they need to use the system that A, they can afford it, and then B, they get treated the way they deserve to be at their time of greatest need. And I think everything you're talking about are really underpinnings to make that happen. Is there anything else you want to share that we haven't already discussed that would help us create that system that's worthy of our family and friends?
You know what I would say, and again, I know that you're at the beginning of your journey, is sometimes less is more, right? So as you're doing
Mm-hmm.
this, I almost wonder if there's a stepwise fashion in which you go about it, right? So whether it's first sharing medication history and saying, hey, this is what we heard. Is this right? Did we miss a supplement? Did we miss something that you're taking over the counter? I would say that almost going stepwise, because then when you get it right, you're like, okay, this module perfect set, easy kind of rhythm. But then when you get into things like social history, smoking history, or even just, physical exam, where are the places where there is often a mismatch, where the patient isn't seeing it the same way, or where is it that the doctor didn't hear it the right way? And then if there is a way to double down on that and be like, what is it about this part of the history or this part of the physical or this part about the
Mm-hmm.
diagnosis that he said, she said? Right? And then if you can actually use that to actually improve the relationship and the conversation, I think it might be surprising. I think it might be surprising because it's often the objective stuff is always going to be easier, right? Like, are you on aspirin or are you not? Right? And sometimes the answer is Monday, Wednesday, Friday. So it may not be yes or no, but the point is you were able to at least get that yes, I'm on it or no, I'm not on it, right? But I think the pieces in the shared decision making that get scary for doctors and patients are the nuance. And so if you can identify where that nuance is and then perhaps find a solution to getting it right, I think that would be tremendous. I
Mm-hmm.
think that would be tremendous
Yeah.
because certainly, I mean, Google Cloud, like there have been any number of sharing of the record, right, that have been done, but inevitably somewhere it falls down. And in my opinion, it's on the nuance, right? Or it's the questions that the healthcare system never asked, which is like, I have 4 pets at home or I live next to
Mm-hmm.
an industrial complex and that's why my asthma is never going to get better. Right. So there's also, I think, some humility to this piece of what did we not ask you that we should have? Like, what are the things that we're missing? And a lot of that goes back to like social determinants of health. But I almost think with what you guys are trying to do, it at least leaves the conversation open for the things we never ask. And it might be surprising the solutions you can offer when you do and you capture them and the
Yeah.
patient says, yeah, that's right. And thanks for asking.
You've been such a passionate and effective advocate for healthcare. I'm sure there's a number of people who are curious about what might be next for you. What can we expect from Dr. G in the near future? Is anything you want to share on that front?
Thanks. Well, I'm working on my next book. I'm very excited about it. I'm terrified it's going to be, you never know once you write one. It's like there's no expectations on the first one. I feel like there's a lot of expectations on the second one. But I think I am going to focus and examine on this issue of trust, especially in a
Okay.
world of AI, in a world of social media, in a world where the consumer is just saying, I've got my own health. Maybe I don't need you, right? Maybe I don't need you healthcare. And so what does that look like and how do we make sure people are healthy? So that's my latest. I also have a 14-year-old starting high school next year. That's a little scary, so I'm trying to balance all of that with motherhood, and I'm doing some fractional chief medical officer work that's keeping me really busy, working with a couple of exciting companies and staying in the kind of the product space in that regard. So enjoying it, definitely enjoying it, but it all continues to be a ride and a journey.
Well, given everything you've got on your plate, I can't thank you enough for taking some time with us today and talking about healthcare. Keep on trucking, and if there's any way we can help, let us know. But thanks so much for being a part of this.
Thank you so much for having me, and good luck with Worthy. I can't wait to hear more.
Thanks. Really appreciate you giving us a listen. Please subscribe, rate, review, and follow us on Spotify, Apple Podcasts, and Instagram. See you next time.